Professor Way, it is such a pleasure to welcome you as a non-executive director to the board of Alcidion. You have a breadth of experience in managing tertiary hospital facilities, together with the associated challenges of workforce and resource allocation on the front line. These are key issues which we are deeply invested in addressing here at Alcidion. The Digital Health CRC and Monash University conducted an 18-month study of the benefits of the Alfred's utilisation of Alcidion's journey boards, which independently established the economic and patient benefits. Are you able to share with us, Andrew, your experience in using Alcidion's products and the benefits that you saw?
Sure, so we think of benefits in two different ways in that context. So the efficiency context is cash releasing and non-cash releasing benefits. And in the non-cash releasing benefits, we're talking about being able to release bed days. So thousands of bed days can be released. That sounds like a huge number of beds, but there's 365 days in a year. So it takes about 1,000 bed days to close and not use one bed. So reducing the number of beds isn't really what we were trying to do, but utilizing the beds. So in 1,000 bed days, think how many patients' admissions could be coped with, managed within those 1,000 days. So that's what we were really looking to see, is how do we make sure that we're looking at this in the way that gets the best use out of the resources of the organization. And that was where the non-cash releasing benefit was really seen. And then there were areas where we could see sufficient change being created that we were able to close resources or change the way in which we use the resources that released expenditure. So the first one didn't make a saving, but allowed us to earn more income. The second one did actually make the saving.
With the benefit of working across the UK and Australian healthcare systems, are there similarities in the need for innovation, and what benefits do you see digitisation in addressing some of these challenges?
So I think the public systems in both the Australian and the UK context are very similar, although within the Australian context, like the UK context, within jurisdictions, so within Victoria or New South Wales or Queensland, it's different. It's also increasingly becoming the case that it's different between England and Wales and Scotland. So the differences of the jurisdictions make it even more similar in the differences. But overall, the clinical governance framework, the way in which we work in multidisciplinary teams, the focus of the patient at the care point, as opposed to the pay at the care point, is a real common features of both systems. I think where we start to be able to do some comparisons is the way in which the private sector makes a difference in the Australian context. So the mix of public and private care gives us an opportunity to look at how patients move between the systems and utilise the efficiencies and differences of both systems, which we can't do in the UK to the same extent. So I think we've got quite a bit of similarity. Where I think there's a real opportunity is because we've got those similarities, can we see whether the overall setting, so the social care setting or the public health setting, makes a difference to the way in which hospitals work?
What do you consider, Andrew, the biggest opportunities for Alcidion?
Developing the way in which the EMR Lite, as I like to call it, so not the fully built out, able to do absolutely everything that only a few places really take full advantage of in the functionality, but provide something that's rich enough for the hospitals that are not wanting that degree of high-tech functionality to use, that provides them with readily available electronic patient records that of themselves then can be summarized into, data can be pulled from, to provide that oversight of the organization. So the individual patient record feeding in an anonymous way into the way in which the organization works is an increasing part of what I think we're going to see in the way in which the data inside the EMR is used. And then with that, I think as health systems bring together different parts, different groups of hospitals, and we're seeing that both in the UK and here in Australia, particularly in Victoria, there's a lot of change going on. We'll see that products like the Miya product that are able to look across the system will look to see how these patient flows go between different parts of the organization and different organizations. So, as much as our community might like to have a heart transplant service at the end of every street, it's not affordable, it's not appropriate. But making sure that there's a rapid and effective flow of patients from their GPs through to their cardiologists, through to their specialists, through to the transplant centre in that instance, where you might only need one of them, or in fact in Victoria we only have one of them. In most states there's only one or none. That flow between, I think, is becoming an increasingly key component of how we allocate resources for particular specialist services. But it's not reasonable that they are most accessible on a geographic basis. It has to be most accessible on a clinical basis. And I think the Alcidion product is working in that way to support the flow of patients on clinical need lines as opposed to geographic lines.
Andrew, what do you hope to see in future as we expand the reach and impact of Miya Precision across the world?
So I think we'll start to see some of the learnings in different jurisdictions. I mentioned earlier the way in which the different contexts of health, social care, public health impact on the way in which we provide services. I think we'll start to see some of those comparisons go further. So in the international comparison space, we're starting to look more and more at what does equivalent care look like, and why for the same procedure are quite different processes and costs achieved. That, I think, will give us quite a bit of insight into, can we determine what's better or best, or what's the equivalent, real equivalent. So a 2-day length of stay in a hospital is easily described, but if it then requires a 3-day rehabilitation admission somewhere else, that's really a 5-day hospital admission in some settings. So trying to get that real sense of equivalence to understand the impact of what we do in the way that the patient experiences it, as opposed to the way our systems record it, is going to be where I think this goes in the future.
Andrew, thank you for sharing your time today and for giving us such detailed insights into the customer landscape for health innovation. A reminder that Alcidion is publicly traded on the Australian Securities Exchange under the ticker code ALC. Thank you for joining us.